But I think for some other patients who are just not familiar with focal therapy, I'm going to give a brief introduction about what is focal therapy, right? Focal therapy of prostate cancer is a treatment that eradicates only the cancer which has potential to become lethal, and leaves the uninvolved prostatic tissue. And the goal here is to have better functional outcome, right? To decrease the burden from morbidity from cancer treatment. And why are we offering focal therapy? It's because, prostate cancer is impacting close to 280,000 men in the United States every year. However, majority of these men are never going to die of prostate cancer. They have a disease which is not lethal. However, we treat almost all of them very aggressively. And when we treat them aggressively, we do take care of cancer really well. However, we induce a lot of side effects. We make them impotent, which means they cannot have erections. We make them incontinent, which means they leak urine. And there are other side effects of surgery and radiation in these men. But while these treatments were the only treatments which we could offer 20 years ago, in last 20 years, our science has given us a lot more food for the thought, right? We know more about prostate cancer today than we knew 20 years ago. We now know in more detail the side effects and shortcomings of a treatment strategy where we either treat aggressively or don't treat at all. We have understood the biology of prostate cancer better, and we know certain type of prostate cancer are very lethal and need urgent treatment. Certain kind of prostate cancer are not lethal at all and can be observed safely. And then there's a middle ground. But I think the biggest thing which has happened in prostate cancer in the last 20 years and has revolutionized the entire field is that prostate cancer has become a visible cancer. Before prostate MRI, we were not able to see prostate cancer. We did a blinded biopsy where we put an ultrasound in somebody's rectum, found the prostate, and put 12 needles in randomly. And then we hope that we will catch the cancer. And when we caught some cancer, we took the prostate out. This is not how we diagnose prostate cancer anymore. The paradigm has changed. Now we get an MRI, we see the cancer, we biopsy it, and then we appropriately risk stratify it. So we have more information about this cancer. So this is the right time to change how have we been managing prostate cancer. And I'm going to highlight those 3 points in the next few slides, right? The first point was we manage prostate cancer either surgery or nothing at all. Is that the right approach? Should we have something in the middle, right? And there have been 3 clinical trials done over the years, one in the United States, one in Scandinavian countries, and one in England, which demonstrated that whether you do surgery on men with prostate cancer versus you don't do anything, you are not getting any survival advantage. You're not prolonging the life of men by putting them through surgery for all comers, right? I'm not saying surgery is not beneficial for any patient, but I think if you just operate on everyone or you don't operate on everyone, those 2 groups will have comparable survival. This is what the studies have shown. Again, there are a lot of flaws in these studies. These are probably not representation of the real effect of surgery on prostate cancer mortality, but at least what we know from the science, surgery did not prolong patients' life in these trials. However, what surgery and radiation did induced a lot of side effects in these men. On the other hand, if we think that we're just not going to do anything for prostate cancer, right? United States Task Preventive Forces suggested that in 2012, like, don't even find prostate cancer, so don't treat prostate cancer. That is probably not going to fly in Western Hemisphere, at least, right? We have this study which selected patients with less aggressive prostate cancer and put them on something called active surveillance, where they were just keeping an eye on the prostate cancer and not actively treating these men. Within 5 years, 44% of the men ended up opting for treatment. And there could be several reasons behind it. Somebody's disease got worse. Somebody got tired of getting repetitive PSAs and repetitive biopsies. Somebody got very anxious and they couldn't sleep, right? So whatever the reason is, not treating every patient with prostate cancer is just not feasible. Again, I'm not saying active surveillance cannot be done. There is cohort of men who would be best served by active surveillance, but using that for every single patient is probably not the right approach, and it's just not feasible in US. So we know that treatment, aggressive versus no treatment, that approach is not going to fly really well. The other second point was about biology, right? We know now that the low-grade prostate cancer cells do not spread to the rest of the body. It's the high-grade prostate cancer cells which spread to the rest of the body. So if we can identify these high-grade prostate cells before they had a chance to become metastatic, which is spread to other parts of the body, and we destroy them, do we really need to chase those low-grade prostate cancer cells, right? And that's the information we have from biology now. This study actually I've cited dozens of times, actually was done at University of Chicago by some of my partners, and it shows that high-grade prostate cancer cells share the DNA mutations with metastatic disease, but the low-grade prostate cancer cell does not. So this disease only arises from high-grade and not from low-grade. And so those were the two reasons why I thought focal therapy should be offered to men who have disease which is somewhere in the middle in terms of aggressiveness. I'm going to stop here for a second and see if somebody has any questions regarding rationale of focal therapy.
I'll ask a question real quick. Isn't it, there's something about how focal therapy, you need a perimeter, a certain measurement around the tumor that allows you to do focal therapy, such that if it's right on the edge of the gland, you can't do focal therapy?
That's a very good question. There are definitely strict parameters to have a successful outcome for focal therapy, and that the list of parameters are, depending upon the grade of the prostate cancer, location is one of the reasons, but cancer at the edge of the prostate, you can treat it with focal therapy. Actually, that's not a bad candidate for focal therapy. It's more about cancers near something important, vital structures, cancer near, for example, sphincter, cancers near urethra, cancers near rectum, right? Those are more tricky cases. Just the edge of the prostate does not make it tricky, but that was a very good question. Yeah, not every man will be eligible for focal therapy. Only certain proportion of prostate cancer patients will be eligible for focal therapy.
Dr. Sidana, what about if there are multiple lesions? Would it be appropriate?
Multiple lesions are tricky. If they are on the same side, yes, the patients will be eligible for some sort of focal therapy. But if there are multiple lesions spread throughout the prostate, that patient would not be eligible for focal therapy. Focal therapy has to be a focal, right? If it's multifocal, then I think the best bet for that patient would be to get some sort of whole gland treatment like prostatectomy or radiation therapy.
Okay, thank you.
Welcome. Okay, so we know now, I think there's not much convincing, at least to this group of patients, that focal therapy has a place in prostate cancer management. But how do we achieve it? How do we get this done? It's more a technical question rather than, a philosophical question. So we get an MRI. We get a high quality MRI, as you see in this photograph. This is prostate, and this large black area is the cancer, and it's called multi-parametric MRI because we obtain multiple types of images, and we review these lesions in these multiple types of images and combine that information together to determine if this is going to be a cancer or not, right? And once we suspect prostate cancer, and you might have heard that scoring system called PIRAT scoring system, that's a scoring system for suspicion of prostate cancer. It does not diagnose prostate cancer. It tells you how likely the spot is going to be prostate cancer. Once we get the PIRAT scoring, we can do a targeted biopsy of the spot and determine how aggressive this cancer is and what's the extent of this cancer. Once we have that information, we create these maps for prostate cancer. And that's what I have told some of you guys, and I tell my patients that having a new map is an up-to-date and current map is very important for successful focal therapy because maps can change. So once we have that information from MRI, we have information from the biopsy, we create maps like that. The blue is prostate and red is the bad cancer, right? And depending upon, and green is less aggressive cancer. So in this case, for example, there's a multifocal cancer. One is bad, but two are not that aggressive cancers, but they're on the same side. So you can destroy all of them at the same time. This is an ideal case for prostate cancer, for focal therapy. There's only one cancer, just destroy it with a margin of normal tissue. Then a more likely scenario is something like this, right? There is a bad cancer in one spot, and there is less aggressive cancer on the other side. In that case, we destroy the aggressive cancer and we just put patient on active surveillance for the less aggressive cancer. So we have information from MRI, we have information from biopsy. We now know that the patient can undergo focal therapy, but which energy modality to use. So when I was in Cincinnati, I did extensively cryo and HIFU. And towards like last year, last couple of years, I've been doing something called IRE. And in this talk, we're just gonna focus on IRE, which is irreversible electroporation of prostate cancer. So what is IRE? IRE is done by equipment, a machine called nano knife. It's
electroporation.
Is there somebody's asking a question? Oh, sorry. So IRE is done by a machine called nano knife. It's developed by a company called AngioDynamics and got FDA approval in 2011 for ablation of soft tissue. So it does not have FDA approval for prostate ablation, any soft tissue in the body, right? So it's a very generic indication yet. They are running a clinical trial, and Cincinnati was one of the sites of the clinical trial, and the trial has now stopped enrolling. But the ultimate goal of that trial is to get a prostate specific indication. So how this procedure works is doctors put these electrodes, electric current electrodes, around the tumor, and then they turn the machine on. There's a positive electrode and negative electrode. So the current flows from negative to positive electrode, and these electrode pairs, you can pair them in any way possible. They have to be certain distance away, and there are certain parameters, but once you follow those parameters, these electrodes will result in destruction or ablation of prostate tissue. So why is it different than HIFU and cryo? HIFU and cryo also destroy prostate tissue. So studies have demonstrated that like HIFU and cryo, they either heat the tissue or they freeze the tissue. So they use thermal energy to destroy tissue. However, IRE does something called non-thermal ablation, where when the electric current transfers through the human cell, it disrupts the cell membrane, and instead of burning or heating it, right, it destroys the cell membrane, ruptures it, and makes big holes in the cell membrane. So all the stuff which is being held by the human cell leaks out and the cell dies by apoptosis. So the claim here is that since it does not heats the tissue or freezes the tissue, it's a better modality in maintaining the vital structures like urethra, like nerves of erections, sphincters. And they are doing the study to prove that in humans that's going to pan out. So these are some of my photographs from my work in Cincinnati. So just briefly go over the procedure to explain to you guys how it works. So patient is asleep in something called dorsal lithotomy with legs up, and we put an ultrasound probe in the rectum. And this box here is called, this is a sensor for a fusion machine, which combines the MRI information with the ultrasound in the operating room. And we get this information where this is ultrasound of the prostate, and this red lining is actually MRI information, which is superimposed on this ultrasound. And this green area is the cancerous spot marked by radiology. So we have all this information in the operating room. And then as a surgeon, my goal is to just put needles around this cancerous spot at a certain distance and make sure that we are able to provide the coverage for that cancerous spot and the surrounding benign prostate tissue. So it's very straightforward and very quick procedure in that regard. And then these are the needles which go into the prostate, and they are actually slightly thinner than biopsy needle, right? So the invasiveness in this procedure is almost as much as prostate biopsy. So no cuts involved, just like 4 or 5 needles going into the prostate, and they look like that on ultrasound, tiny white dots covering the area of cancer. And then we just turn the machine on, and the electric current goes from 1 to second dots, second to third electrode, third to fourth electrode, fourth to first, 1 to third. So we pair them so that every single pair receives enough electric current to destroy the tissue between those electrode probes. And this is the setup of the machine. Ultimately, if you see, this is before ablation. After ablation, this gets all like dark and fuzzy because prostate is getting destroyed in that area. Since we can see things really well, we can limit the destruction to the area of the cancer and avoid damage to, for example, stuff like rectum, nerves for erection, sphincter, this is urethra. So we can avoid that damage because everything is just super visible, basically. So the question is, yes, everything, this sounds pretty cool, makes complete sense. Physics makes sense, biology makes sense. Does it work, right? So this was one of the studies, initial studies done in Europe on 45 patients. This is like relatively older study. And it demonstrated that, almost 70% of the men were cancer-free at the second biopsy, which is pretty good. Like you got something done, which is probably as invasive as prostate biopsy, and the cancer got treated in 70% of the men. Then there's a bigger study. This is from Germany. They treated 471 men, and their results were really good. They did all sorts of ablation with this. They did focal. They destroyed the entire prostate. They destroyed half of the prostate. They treated all sorts of men, low risk, intermediate risk, and high risk, men who had prior radiation, men who had prior treatments. So they did all that. And despite that, their outcomes were excellent. None of the patient become incontinent, which means they never had to wear diapers and pads. Majority of the men maintained erections after this treatment. So what was known in the biology was proven in this treatment in Germany, in this paper in Germany. So we did several of these cases in Cincinnati. Some of them were done as the part of the clinical trial, which this company is running in US, because they don't have FDA approval for prostate ablation in US yet. So we did some of those cases, and I think we're one of the highest enroller in the country for that clinical trial. But we also did cases off trial as a part of a prospective registry. And before I left, we had done 22 cases, and our outcomes were similar to what the previous studies have shown. The PSA on these men dropped down significantly from, for example, preoperative PSA was 8 in our patients, and at 12 months it was only 2.5. So dropped down more than 50%, and we use 50% as a cutoff of success or focal therapy. So these patients had 75% decline in their PSA, which I was very pleased about. When I looked up their urinary function and shim function, which is shim is sexual function, so their urination got slightly better. And that's been explained by, when we destroy prostate tissue, it kind of shrinks down and scars, right? So their prostate volume goes down, so their urination gets better because now they have not as big prostate blocking their bladder. That's what we showed that with other modalities also, and IRE also demonstrated similar result. In terms of sexual function, we noticed that there was slight decline. And so this is not a modality where we can claim there was no decline at all, but our numbers were really small at 12 months. And our hope was, like, if you see at 6 months, the number, we started with 13.8 and it was 12.23. So men who reached up to 6 months, they had already recovered their sexual function. At 12 months, we had only 3 patients who reached this follow-up. So we don't know if this lower number is actually a true number or this will improve as we follow these patients for a longer period of time. But overall, I was really pleased with urination getting better and sexual function not getting a significant impact. Okay, so we showed the treatments were easy on patients, no significant problems, urination better, sexual function better. Does it work on the cancer also? So again, our data is not long-term, it's a very short-term data, but at this point, we demonstrated that only 2 out of those 22 patients failed this treatment. And again, only time will tell how good this treatment is, at least in my hands, and hold up with the results be similar to what Europe and Australia has demonstrated. But so far, it is behaving as we expected. And there were only 2 out of 22 patients who failed in the first 6 to 9 months. So in conclusion, focal therapy is a treatment which can be very personalized option for prostate cancer patients, right? You can destroy a wider area, you can destroy a smaller area, you can destroy for certain locations, you can use freezing, or certain location you can use burning, for certain locations you can use IRE. So you can personalize the treatment option based upon what the location is, what's the grade of prostate cancer, and how good is the functional status of the patient, right? You could not do that with prostatectomy. It's the same for every patient. You take the prostate out. With focal therapy, you can dial it up or dial it down depending upon how much aggressively you want to treat a patient. It has been shown to be safe and feasible, and there are a lot of studies over the last 20 years, a lot from Europe, fewer from America, but I think we have still built up enough evidence that it is definitely safe and feasible. we have outcomes, cancer outcomes in short term and intermediate term up to 8-10 years, and they are excellent. We just don't have a long-term outcomes with focal therapy going on for 15, 20, 30 years. And that remains to be seen. Is this treatment strategy, is it going to hold up for 25, 30 years? And or would it turn out to be something which was not the right thing to do for our patients? But that's why I think we need to do the studies. I put every patient through a database and or clinical trials and collect data on them. And if some of you guys are my patient, you probably know how OCD I was about collecting data on every single patient, because we need to know that we are doing the right thing for our patients. Irreversible electroporation or nanoknife is a novel method for focal therapy of prostate cancer. It got FDA approval for soft tissue ablation only in 2011. And only recently, I think 3-4 years, we've been using it extensively for prostate cancer in America. And they still have their first trial ongoing, which will tell us exactly how effective this treatment is and how safe this treatment is for prostate cancer. So until that time, I think we need more data before we start offering it as a standard of care treatment. And I think we should, and the guidelines have said the same thing, we should offer these treatments as a part of either a registry where you collect the data or as a part of clinical trial for that reason. Thank you. And this is the urology call center.